So welcome everyone to the Australian and New Zealand Academy of Eating Disorders webinar presentation from James Locke on what is a very interesting topic, adjusting FBT for adults and ARFID clinical considerations. My name is Martin Pradell. I'm from the Royal Children's Hospital in Melbourne, and I can see we have quite a few people from Australia and also New Zealand, which is great. And it gives me great pleasure to warmly welcome Professor James Locke at the end of his day there in California. So thank you for taking the time to share your knowledge and expertise. James is the Professor of Child Psychiatry and Pediatrics at Stanford University and an international authority and collaborator in research into effective treatments and neurobiology of eating disorders in children and youth. He is the co-author of the Family-Based Treatment Manual and a key figure in dissemination of FBT across the world. He has published over 200 articles, abstracts, books, and book chapters. Just a few housekeeping matters before we move on to the presentation. You can listen to the webinar via your computer speaker or by dialing in via the phone number on the screen that was previously there. But if you dial in, you need to turn off your computer speaker by clicking the speaker image at the bottom left-hand corner of the screen. If you notice the screen has frozen, you can refresh the screen by clicking the blue circle with the white X at the top corner of the screen, then click the orange button to reload the conference room in your browser. For any other technical difficulties during the webinar, make a note of the numbers of the screen, which was there previously, to dial for technical assistance. Otherwise, we will have time at the end of the presentation for question time. And we do encourage you to send your questions or comments via the chat box bottom left. Just press enter after your comment or question, and I'll do my best to collate them for the Jim at the end of the presentation. So on to the presentation today. Jim will outline the ways in which FBT can be modified for young adults and for children with avoidant restrictive food intake disorder, a new diagnostic classification in the DSM-5. I'm very much looking forward to hearing what Jim has got to in adjusting FBT for those specific populations and how this process has occurred. So over to you, Jim.
All right, thank you very much for having me, everybody. I don't know who all is here, but very odd to speak into a universe like this. So I'm going to speak for about half an hour and then leave about 15 minutes for questions. That's my understanding of the timeline. Is that right, Martin?
That's right, yep.
All right, so I'll keep some eye on the time. So there are two topics, and they're related in my mind in terms of adjusting family-based treatment or the principles of it for adults and for ARFID. And we'll just talk about some of the reasons why I think they're related. First, just thinking about older patients to begin with. This is a survival curve. It's from one of our studies where we had age as a variable. And if you're looking on the vertical axis, you're looking at recovery rates over time in months. And what you notice here is that recovery in the green and the blue areas, which are the 14 to 16 and 15-year-olds, is much higher than those above 16. And this isn't specific to FBT. This is a study where we compared it to individual therapy, where we actually thought that older patients might do better in individual therapy, but we actually didn't find that to be true. But everybody did better if they were younger. And that's important because it tells us that response in younger patients is going to be greater than in older patients, which on the one hand, it makes a lot of sense just intuitively. On the other hand, this poses a challenge for us. This is a slide which is a similar kind of slide. It has recovery rates, that is illness rates dropping on the vertical axis over time, and time is in months. So each of those diamonds represents a longitudinal study that was conducted, and outcomes in this case were defined really basically as no longer meeting DSM-4 criteria for anorexia nervosa. And of course, at the beginning of the study on the far left, studies you see everyone's ill, but over time, what happens is by about 5 years, you can see that the response rates really flatten out, and you're left with about 15 to 20% of patients who are unlikely ever to recover. So again, it's important to understand that the patients that reach a 5-year duration of illness, and for anorexia nervosa, if its onset is 14, that means 19 or 20-year-olds. You are looking at a very low chance of recovery. Again, in this case, pretty low bar for recovery, just no longer meeting DSM criteria. This slide shows you 9 of the studies that were published in the last number of years, which shows just how difficult anorexia nervosa is to treat when they become chronically ill. Attrition rates are about 50% on average. And although the 2 recent studies, the one from Germany being the best of those, and the one from Australia being also a very strong one, did show better effects in terms of lower dropout rates, but they have to still be viewed as exceptional, and it's very hard to explain why those studies were able to keep patients in differentially. And of course, clinically, we all know that these patients are very challenging to keep in treatment, randomized clinical trial or not. So why, given this sort of dark cloud that I just hung over our discussion here, would FBT be considered? First of all, there is some limited research. Gerald Russell's study in 1987 and Dara's study in 2001 both used family-based treatment or something akin to it in adults. And although there wasn't superiority of family-based treatment over other treatments, it was at least as good as the other treatments that were studied, which were CBT and CAT. The other reason to consider it is many of these young adults are still living with their families. They're unable to get out of their families, so because of their illness. So there is a reason to think about family work. And the last reason is that we have done cases now of transition age and older adults with anorexia and found that at least in some cases, FBT is useful. These were the 2 studies I just mentioned where FBT was compared to individual therapy by Russell et al. And by Dare et al. And it is in both cases, although there were no differences, most of them do very well anyway. So how might FBT, to the heart of the matter, how might FBT be adjusted for young adults? Well, those of you, so although Martin introduced me as a co-author of the treatment manual for anorexia nervosa, Daniel and I also wrote a treatment manual for bulimia nervosa for adolescents. And that manual, although less, I think, appreciated at this time than the anorexia nervosa manual, shares a lot of features with the other manual, but there are different points. And at least to my way of thinking, when you're thinking about young adults with anorexia, they could be approached very similar to how we recommend treating adolescents with bulimia, and that is beginning a starting point with a negotiated beginning. So unlike with anorexia nervosa adolescents FBT, where we basically ask the parents to suspend listening to the debates that anorexia gives them from their teenage daughter or son. With bulimia, we ask the parents to actually engage in a negotiated starting point with their teenager to get an agreement that she will or he will allow them to assist with the problematic behavior of binging and purging. So For FPT for young adults, we think that that is a necessary beginning. These are people, young people who have some legal abilities to manage their own care and are more autonomous in many parts of their lives. So, like the bulimic adolescents, who are often much more like typical teenagers than the younger adolescents with anorexia, the bulimic ones, adults, young adults are in that same frame of being more advanced in their adolescence in some respects. So we asked the parents to negotiate the beginning point with their daughter or son as we would in bulimia. Second, we believe that you have to take into account the real developmental control that these older patients have. So again, unlike what we would do with an adolescent, we would actually really encourage parents to take no uncertain terms, take charge of eating. We would want to make sure that parents did that as much as possible, but still taking in a much more negotiated way control, so that we don't have the absolute starting point of rejection. We also think that because these older patients often have to eat, they may live apart from their families, they may be in college, they may be dating people, that they actually may need dietary advice. Unlike, those of us who work with FPT know that we actually really discourage getting another expert involved in meal decisions and meal planning when parents and the therapists are working on this in FPT. When a young adult is actually going to be responsible for shopping for herself and managing some of her meals, dietary advice may be useful to her directly. In FPT, at least in the way that we normally think about whole family FPT, we really like siblings to be there to support their brother or sister while they're unhappily being refed usually. And here, siblings are unlikely to be as necessary. Instead, other significant others, like romantic partners or best friends, might be the kinds of relationships that might be brought into the therapy, at least intermittently. As those of you who have looked and know something about FPT also know that it's typically not a very lengthy therapy, about 9 months, 15 sessions on average, and that's true because you can move through that treatment efficiently in the patients who are responding pretty well. It's likely that it's going to be much harder because of the negotiated processes involved for the dose to be, it's going to be longer and it's going to be greater. Also, as you know, in standard FPT for adolescent anorexia nervosa, the individual work doesn't focus at all on cognition or expression of any other kinds of emotions or management of other issues until and if the other work is all done in terms of behavioral change and eating and gaining weight. Here, because the illness has been present usually for 4, 5, 6 or more years, the deep seeding of those cognitions and emotional conflicts with parents and friends might need to be addressed, and likely will be need to be addressed. And so instead of just a brief 10-minute session that we have with the adolescents with anorexia, here it is likely that we would recommend that we would have more individual work actually set aside more time for actual individual sessions. This does two things. It supports the young adult staying in treatment, tolerating the parents' refeeding efforts, tolerating the therapy even though it's really very, very challenging for them. And second, it allows you to actually do some other kinds of relevant work that otherwise is often not necessary for adolescents or younger. So this is a chart that kind of summarizes for young adults how we think about the difference between these organizing treatment for these two different age groups. Of course, both treatments are agnostic as to the cause of anorexia nervosa and doesn't blame anyone for the illness, the parents or the young adult or the adolescent, so that doesn't change. The therapist remains a consultant and does not prescribe treatment in either arm. As we talked about, parental empowerment is quite clear in adolescent AN, but it's much more negotiated in adults. The therapeutic alliance, although it is somewhat, it's something that you consider with adolescent anorexia nervosa, it is much more important, likely, with the young adults. Motivational enhancement to use therapy, we don't use that much at all in adolescents with anorexia because basically we motivate the parents instead. With the adults, it may be necessary or useful to think about early motivational techniques to help the young adult consider negotiating with their parents to help them eat more normally and to gain weight. The externalization procedures, which are part of FBT, and very standard separation of the illness from the patient and so forth. It's very clear and easy to see in the adolescent with anorexia nervosa because they haven't been ill very long, and people can remember very clearly who they were and what they were like, and as opposed to how they are now when they have anorexia. In contrast, with someone who's more chronically ill, their whole lives and their whole personalities have been steeped in the anorexic brine for long enough that a lot of times it's hard for everyone to remember what she or he was like before the illness came on. So when I say it's a moderated externalization, it's recognizing the fact that the cognitions, emotions, and behaviors have had more permanent effects on personality, interactions, and so on. So it's harder to externalize. And again, the behavioral focus that we have in anorexia nervosa about weight restoration and all the management of behaviors that support weight loss and instead challenge the efforts to over-exercise and not eat enough is very clear in adolescent anorexia nervosa. Because, again, the illness has been around longer, it is much more moderated. We need to think about other aspects of their lives earlier in treatment, how they're relating to other people, the conflicts in the family around things, and their friends and their work life even. We don't do much in family process that isn't related to changing behavior in certainly early parts of FBT, but in adult, we really do have to attend more to family process. There's usually an awful lot of water under the bridge by then, such that people feelings are raw and or conflicted, and there's a lot of anger and frustration that makes it, and that is more entrenched than it would be in the shorter duration illness that we see in the adolescent. So you often have to do some more general family work as well. I talked about individual support, but it's limited in the way that it is in adolescence to the brief time at the beginning of sessions, and how there might be likely need to do more of that collateral work with individual therapy with the young adults. As you know, when we talk about adolescent anorexia nervosa, we're talking often about getting them back on track for adolescence. Instead of being on track for adolescence, we're trying to get these young adults back on track for the young adulthood. And those tasks, although sometimes related to late adolescent ones, are going to be much more consciously thought about as work related and relationship related. There isn't a cognitive focus in FBT at all. There is likely to need to be some work on cognitive distortion in the adult side. We talked about siblings, and we talked about peers and dietary advice. Medical surveillance, which is a necessary part of the work of adolescent anorexia nervosa, is often not included in working with young adults and adults, and I think that's a real tragedy, because they're actually, although they may appear to be superficially stable, they are actually going to be a greater risk for death over time than the adolescents who are acutely unstable and worrying. So having a good team is still essential, in my view. There's a lot of comorbidities common with these disorders, and one of the things I would point out is that it is, we defer all the comorbid treatments to get anorexia out of the way, because it's the most lethal and less suicidality emerging. However, in sort of sequential, you do the FBT, you get the anorexia out of the way, and then you might treat anxiety disorder or PTSD or whatever might be there. It's much harder to do that, both in bulimia and in adults and more chronically ill adults with anorexia. And so the treatment has to allow more flexible work on some of the comorbid realities. And the dose, as I said, will be short versus long. So just some concluding observations about FBT for adults at the end before we talk about RSID. Right now, there's a manual that's been developed for FBT for transition age youth. A version of it is published in a new volume that Catherine Loeb Daniel and I just published by Routledge. Routledge is the publisher. It just came out at AED this past month or so. It's called Family Therapy for Eating Disorders, New Applications. And the first editor is Catherine Loeb, L-O-E-B. And there's a chapter that goes into more detail about how the treatment can be adjusted into some case examples. There's a case series being developed in Canada. Gina Dimitropoulos is in charge of that study in Canada. So hopefully we'll get a little more information about just how effective some of these ideas that we've been working with are in a systematic way. In my own experience clinically, families of older kids, despite the limited data, have asked very often for us to try to use FBT with them. And so if they're motivated and they can help their young adult child to engage in treatment, that is that's a great indicator for being able to give this a try. The adjustments I talked about are important to consider. The course will likely be a whole lot less predictable. One of the things that we really now know an awful lot about how patients who are adolescents typically respond when they're going to respond. We know about their weight. We know the kinds of behaviors to expect. It's a much more even and still unclear outcome. Also, we early on in our work, it was clear that the outcomes that we should aim for adolescents with anorexia nervosa should be very high. We should look for absolute normality in terms of eating and weight and thoughts and concerns, because it could be achieved. And if we did that, the chances of relapse were going to be low. And again, a recent paper that came out with Daniel's the first author in JCAP about 6 or 8 months ago on one of our studies, just shows that relapse, once you achieve true recovery, in the way that we're talking about now, normal weight, normal EDE, really is a great protection for relapse. Probably for adults, we need to be more realistic about what we can achieve. better outcomes, but maybe not the same level of change that we might expect in younger patients. As I said, it's likely this therapy will need to be much more complex, combined with other therapies, and more emphasis on ACEs2 and 3, as we discussed, because these are people who are going to be living their lives right now, not like a 14 or 15-year-old, but they're off in college trying to work, trying to have relationships. These are people who actually need to manage things, so that transition in phase 2 and the challenges of young adulthood and adulthood of phase 3 are likely to be more important. I'm going to skip the case example for the moment and turn to FBT for ARFID. I want to keep track of time. So these are the criteria for avoidant restrictive food intake disorder from DSM-5. And one of the things I just want to be clear about is that patients who meet ARFID are a mixed bag of patients. They're not nearly as coherent a population as anorexic patients are, or even bulimic patients are. They need to have these disturbances in food and eating, and they're not due to anorexia or bulimia, and they're not usually focused on appearance or weight concerns. Here are some differences that I think are really important in terms of thinking about ARFID. Usually there is either an acute or chronic process. So if there's an acute trigger for ARFID, for example, a swallowing difficulty or a choking event or a medical event related to an allergic reaction that leads to someone being afraid to eat or swallow, that's very different than the kind of acute triggers that we usually find with anorexia. It's usually chronic concerns in an anxious person. And then but the other group are these kids who have been chronically allowed to eat in a very restricted fashion, usually from very early childhood. These are kids who have food sensitivities, texture sensitivities. I call these the white food eater boys usually, and these are the ones that starting at age 1.5 or 2, they eat Cheerios and white bread and mush and things like this, spaghetti with no sauce, that kind of stuff. And that's been a long-standing issue. Very different group of patients, but both of them are going to fall into ARFID, and it matters. You're going to think about them somewhat differently. These are usually younger patients. These are usually not going to be patients that are teenagers, but they're going to be latency age or school-age kids. And so that changes parental empowerment, in some ways making it easier in some ways. The developmental course, there's 2 different courses. There's the one that's got the acute trigger where the kid suddenly has an event and then is afraid to eat and then begins to lose weight, and then there's the long chronic course of the selective restrictive eaters. These illnesses are often worked up ad infinitum medically. A lot of GI people involved, and so there's a worry about the organic basis of these illnesses, which complicates their treatment. And their comorbidities, instead of anxiety and depression, which you see with anorexia, you see a lot more of autism spectrum problems with ADHD and other kinds of anxiety disorders. So here's that chart that we can put in parallel with the chart I just talked about with young adults. And we have here the same categories looking at ARFID as opposed to adolescent anorexia nervosa. And again, you can be agnostic, but it's a little trickier when you actually know that there was a food allergy that triggered these initial events, or there was a traumatic event that actually started this kid on a course. So regardless, though, the non-blaming stance, that part is still the same, even though you may have some clearer idea than you would anorexia what the etiology is. Again, it's a consulting kind of therapy, not a therapy which directs parents. Parents are empowered to change behaviors and encouraged to find ways to do it. Therapeutic alliance is important across the board with parents and children in the same way for both these treatments. There isn't a role, I think, for a formal motivational enhancement kind of process with these kinds of kids and families. Again, with externalization, you have a much more moderated one in ARFID, because sometimes you can't totally externalize it because there is actually an allergy to something or there has been a real event. So although it's separated, it's still like with the agnostic presentation, trickier to do it in the way that you do it for anorexia nervosa. Both are really behaviorally focused, but in pretty different ways. Often in the selective eaters who've been ill for a really long time, since they were little kids, the family has so accommodated to their eating patterns and have gotten used to the drill, as it were, of their selective eating, that it's extremely challenging to get them to even think about making real behavior changes and stand up to the accommodations that we've made over usually 5 or 6 years period. And in this way, they share some similarities with the adults with anorexia nervosa, where the family has often accommodated to the eating processes of anorexia. In both cases, these are young kids. I think mostly there's just a need for some limited support, as we would do in adolescent anorexia nervosa. No real call for a separate individual therapy. As I noted, these are younger patients, so they're not likely to be needing to have a focus on phase 3 on adolescents, and they may not even need a phase 3 at all. There's no cognitive focus really in FBT for ARFID. Siblings, it's interesting, there may be some role for siblings in ARFID, depending on if there's someone relevant and helpful. Again, in the more chronically ill ones, it's harder because they've accommodated as well, don't really see the urgency. In the acute ones, sometimes you can bring a sibling in for support. It's interesting to think about with ARFID, particularly the ones for parents where this is selected eater, if they might need additional education about the kinds of foods that are needed for health, and so additional dietary advice for the parents might be a helpful addition. Both of these groups, although these kinds of ARFID are subject to weight loss and medical instability as a result of that, and they do need to be very carefully managed. Again, with ARFID, you often have ADHD or problems with autism spectrum behaviors that you may have to concurrently manage in addition to the management of behavioral problems related to eating. And again, particularly with the selective eaters, that's been a long-term problem, you have, you're likely to need a longer dose. The acute ones, the ones that have a phobia to a particular kind of food, or they're swallowing something, you could probably expect a much shorter course. So this is just an example. Layla is an 11-year-old girl who is increasingly restricted her intake of solid food after choking on a hot dog at a school picnic. She complains of soreness in her throat, choking sensations on swallowing, restrictions of intake to fluid, school refusal, weight loss of 8 kilograms in the past 2 months, and she denies any weight and shape concerns. So in many ways, this kid's weight loss and her behaviors, although having an acute stressor, are really similar, and you can think about doing FBT really similarly. how you would manage a person with anorexia, except they're younger, and in this case, the fear, which is a choking, less about food, has to be managed in a very gradual, desensitized way, lots of exposures. So in many ways, quite similar to what you would expect for adolescent AN. So the kinds of issues that come up, how does the family conceptualize the problem? Do they see it as a post-traumatic problem or a behavioral problem? Helping them understand and conceptualize the problem as a behavior one is usually useful. The difference between anorexia and the real fear, based on real fact, she had a real choking event. It's an imagined event, obesity in the case of anorexia nervosa. The family needs to process those differences and think about those differences. And the therapist needs to think about how they're going to manage that difference. And one, desensitization, food intake, and weight gain, really just food intake that you're really looking at, and weight gain, but there is some desensitization that you're going to have to work on more directly early on in FBT for ARFID. And there's a question as to whether you need to go anything further with this kind of patient than after a phase 1. And other treatments that might be needed depends on if there are other comorbid conditions. Here's another case, a more chronic kind of ARFID. Sam is a 9-year-old boy with a diagnosis of autism spectrum disorder. He's in mainstream schooling. He's active in sports and has friends. His diet consists of white, soft, and sweet foods since early childhood. He complains of the taste, texture, and smell of other foods. He's highly resistant to trying new foods. He's below the 10th centile for weight, height, and age, and he wishes to be bigger and stronger. So what are the issues? First of all, this is a young kid. They often are 7, 8, 9. The doctors begin to worry about them, and the parents are worrying about them for a while. He doesn't see a problem, but do the parents. And so externalization is hard. They've accommodated so much. How do you make this urgent? And can you make the need urgent? This means really stepping up the issues around growth retardation, around failure in height, developmentally falling off the curve in terms of being able to participate in activities and sports that he wants to with his peers as they're growing. So these kinds of things are ways that you can begin to light the fire under the family around changing the behavior, because he's going to resist it and fight the externalization. You need to have really clear guidance from a medical team and dietitian about, where he should be, and probably the specific goals need to be set very, very in a graded way over time. Sam would be a case where you're likely to treat him and the family for a longer period of time to help them make change. So, FBT may be more effective, in my view, on acute events like trauma. And I noted in both cases probably less emphasis on phases 2 and 3. Externalization and motivation in the more chronic cases, where there's been just years of accommodation, are going to be challenging. And these disorders are ego-dystonic for the most part, which gives you some hope that you can actually enlist the kids in the process, but they're usually so young. That's your connection as well.
Jim, if you can hear me, I think you might need to reload the browser by clicking the top X in the top right-hand corner and then the orange button. Everyone, sorry, we're just trying to get Jim back. Sorry about the delay. Hopefully it won't be too long.
Yeah, something happened. I'm not being able to get even back to the page. Here I am back to the participant. Maybe I can do it now. It's reloading.
Wonders of technology.
Yeah, great. All right, it's back up for me. Can you see it again?
We're on slide 20.
Yeah.
Right.
And that is the last slide. So now I'm open for questions. Martin? Hello?
I might just, if Martin is having trouble getting back on, I might just go back up the list and ask the questions in order, although that will be going back to the young adult application. So
that's fine.
Quentin asked about how the externalization process is moderated in adult FBT.
Well, what I mean by that is you would say maybe you can remember times when at home now she is less concerned about eating and weight when she's working on her college homework or she's talking with a friend, as opposed to when at mealtime or when she's at the store. So they can see short term rather than long term. With a kid, you would say you can remember just a few months ago when she was living her life without anorexia at all. You can't really say that she's been living her life without anorexia at all, usually in these cases, because it's so chronically present. That's the kind of example I would give.
Karthik, I'm back on now. Is that right?
Yeah, over to you, Martin.
Okay. There's also an interesting question by Chris Thornton here. Would the same strategies be applied to adolescents who don't respond to manualised FBT as you described for the adult adjustment?
No, I don't think so. And for a bunch of different reasons. They are not chronically ill. They are not young adults. They are not autonomous. So from my perspective, no. For those who don't respond, actually what I think we need to be thinking about are other strategies that fit this age group. One strategy which we're really interested in is increasing parental coaching, direct coaching around mealtimes for patients who don't respond by 4 weeks. And this is a study we've been doing in which we hope to, we're just doing the analysis now, and I think it will be very, very clear that you can change the course of these non-responders, at least a big chunk of them, by helping the parents more directly in the short term in repeating efforts. And the second is maybe another study which we've been involved in, which is trying to actually facilitate the thinking style rather than the content using cognition. These complement FBT, they don't run interference with it. So I think it's quite different. I think it's different.
Okay. There's also a question from Quentin. The rationale for more general, not just behavioural family focus in adult FBT, because the patterns are more entrenched, thus is there an argument for a broader family focus whenever the patterns are entrenched and hostile? Just wondering the shift towards family focus and rather than behavioural focus inclusive.
Well, if I understand that right, it's something that I spoke to, that I do believe there's going to be a more general systemic family focus in the more chronically ill patients, as well as the behavioral focus. So you're going to have to combine them,
right, because
of the likelihood that the illness has had more long-term impacts on the family and its interaction.
And I mean, just on that one step further, you talked about the individual piece and perhaps spending more time with the adult in that first period in FBT, what would that look like just in terms of addressing cognitions? What is it that you would notice if we observe in that session as opposed to standard FBT?
Well, we don't do any cognitive focus in standard FBT. So I think if you kind of think about it in 3 parts, one, you might early on be
Hi, this is the operator.
motivation.
I think we're right.
Hello?
I think we're all right. Yep.
No problems at all. Thank you.
Thank you.
Okay. Sorry. So early on, you might be doing work that's designed to keep the patient motivated and engaged with allowing their parents to refeed them. As they make progress and they're working more at managing their own eating in a phase 2 kind of way, you might actually have to work on cognitive distortions and beliefs much more consciously like you would in CBT. And then finally, you might, as you moved into phase 3, be talking about the impacts of their preoccupation with eating and exercise on their relationships with others, their friends, their partners, and so on.
A question from Jenny. What kind of clinician
you don't do any of that with adults?
Yes. Yep.
Sorry.
It's okay. What kind of clinician should or could deliver FBT for adults? Is the experience of FBT for adolescents essential, or could clinicians who generally work with adults use this approach?
Well, that's a good question. The answer is I really don't know. I wouldn't have been able to answer this question about FBT for adolescents 10 years ago. Now I'm pretty clear that you need to have training and you need to have experience and supervision to be very good at it. And my guess is that would be true here too, that if you were going to try and do this more complicated version of FBT, which integrates CBT and motivational enhancement and family systems work, you're going to need a pretty sophisticated therapist. That shouldn't be a surprise.
No, that's fine. Yeah, that's absolutely. And just on a little bit further in the similar sort of theme, is knowledge about adult FBT based on adult onset cases or chronic cases? And does this make a difference to the process or outcome? So I guess I'm interested also is whether you get returning young adults who have done FBT in their adolescence and then come back for further intervention, and whether that has any influence on outcomes.
So I don't think we know the answer to that. I would say that our experience has mostly been with people who have not been treated effectively by other treatments than FBT and or 4 or 5, 6 years into their illness.
Right.
So they were treated in individual therapy, or they were treated in a day program or hospital or something like this, and they got somewhat better maybe, but they really stayed pretty ill, and they're ill at 19 or 20. So it's mostly those kinds of cases that we're talking about.
Yeah.
That we've had experience with.
Okay. Right. A question from Mandy. So for chronic food allergies and IBS-like presentations, can you say something about how to manage both the food intolerance and increased exposure to broader, more flexible eating?
Right. Well, I think the question's right on. You have to balance those two things, right? You have to take into account all the allergies. You obviously can't change those things, but you don't want the eating to be so restrained around everything out of fear that they're going to have an allergic reaction every time. So you have to have as a therapist, you have to help the family think through the need to expand this for their child's health and bigger picture and then they can decide the risks that are associated with each of these new foods that they're introducing. Most of the time, the allergies are pretty specific, so that the fear gets generalized. So if I understand the question correctly, it's going to be a lot of exposure to foods that are non-allergic foods.
And I anticipate there's relaxation, visualization, those kind of interventions of trying to impart relaxation to the family system. So how do you actually do that in a practical sense to get them on board with that?
Well, the families with the ones that have acutely lost weight are very similar to the anorexic patient. And if they're nervous, they're worried about their child, so it's easy to get them on board. It's the selective eaters that you have a much harder time getting them on board because they're so accommodated, they're so used to it, they're tired of the struggle. These parents see that this has happened over the last 6 or 8 months, and they see a really big difference in their child. So oh no. Did it go away again?
No, you're still here. Yep.
So okay. Well, it went away on my computer for a minute.
Right, okay.
So it's not so hard for them to be motivated. They really, they can see the physical effects pretty quick.
And I guess, I mean, perhaps also I'm thinking here with the young adults, I mean, how do you, as opposed to standard FBT with adolescents, there's the medical crisis that sets the scene for mobilisation and adjusting anxiety. How do we achieve that with young adults when the family or the partner or friend may have less investment in being part of treatment long term?
Well, I mean, there's a couple of things about it. One is that, the primary motivator when you're doing externalization isn't just the acute medical situation. It's the fact that over time, the likelihood of death now has been increasing in this young adult by about 1% a year each year she's been ill. So she's getting closer and closer to really intolerably high risk. The medical problems are going to have been very clear by then. There are going to be problems with bone loss and probably injury from over-exercise and maybe fracture. There's going to be a lot of things that you can document that get at that externalization piece. By the way, I meant to mention that in that same book I mentioned earlier on young adults, there is a chapter on OFID as well that Tara Fitzpatrick is the first author on. And I recommend that chapter as well.
Great. Question here from Melanie. Would the adult FBT, I think it's a similar question to Chris in some way, but would the adult FBT strategies be recommended in adolescents with chronic illness, e.g. 16-year-old with 5-year history who is not responding?
Yeah, I think so. I think so, yes.
Okay.
Yes.
So we're learning something from the young adult model that we can bring in as it sits with your data as well in that first slide that we can bring into the 16, 18-year-old sort of group.
Right. Yeah. If you showed that second slide to families or you had that, were able to talk about that, it's pretty, pretty strong data.
And from your experience working with these I guess FBT adjusted models, how do you find personally kind of working with adolescents with anorexia and bulimia versus with young adults and ARFID?
Well, I've had a lot more experience with the adolescents, and what I would say is that when it works, it's really rewarding because these are really rocky often at the beginning. There's a lot of trouble with the negotiation. I just sort of talked about it as a negotiation, but what it is, it's pretty brutal at times. The parents have to say, you may not be able to live with us right now if you don't agree to this. There's a lot of struggle. But when they actually begin to get better, it's so rewarding because these are kids who would be heading to a really chronic, very bad outcome.
Okay.
And,
I've got a...
you know,
sorry?
that's a reward.
Yeah, I can imagine. Absolutely. Yes. And just a question here from Amanda, and this may need to be the last question. Amanda from ISIS, the Issues Centre here. We've had some success working with adults with long-term AN who have multiple hospital admissions with combined IPT, psychiatric monitoring, and utilising peer support. Slow incremental recover with focus on addressing trauma history, skills for living, empowered communication in family, and building greater social networks. It's a comment. Any comment from you in relation to that comment from Amanda?
You know, I don't think we know how best to help these more chronically ill patients. You know, I've talked about FBT, the rationale that I gave is what it is, and the reason it might be useful in the clinical experience that we're building. I think it'd be great if they actually do a case series and show that there actually is a treatment effect of their approach. It would be a great contribution to the field, because we don't know how to help patients who are chronically ill. We're still learning, you know, bit by bit how things that might be helpful. So I'm really glad to hear that they have something they feel is helpful, and I hope they'll document that. Yeah.
Okay, I can't let this one go. So there's one more question, and this is with a final question. In FBT young adults, to reduce ED behaviours and promote age-appropriate independence, do you target family variables that restrain independency, e.g. high expressed emotion, communication deviance, and overprotection?
Well, you might. You wouldn't be targeting those as a general rule. What you'd be targeting is any of those things that interfered with either keeping the parents able to help the adolescent, the young adult, or vice versa. So if the parents are yelling at their daughter all the time, and it's clearly, you know, the level of expressed emotion is high, you would want to help the family know that that's probably not helping. So, so I wouldn't be thinking about it as general, in a Minuchin sense, these variables or something like this, but I'd be thinking about them more in the context of FBT. Do these kinds of interactions help you with what you're trying to achieve? And that's different than working just purely on a systems basis, right?
Okay, I think we'll finish off. We've run out of time on what has been a very interesting presentation and discussion. So thanks greatly to Jim for sharing his clinical and research knowledge with us today. I'm sure there's lots of interesting ideas for us to consider in our everyday practice with these population groups. And thanks for your questions and comments along the way. ANZ AED look very much forward to having you join us again for the July webinar by Dr. Stuart Murray on the topic of males and eating disorders. I think that's all for now, so bye to everyone. Thank you.